organized by the Health Systems Global Action, the group, thematic working group on action on accountability and anti-corruption for SDGs. Our group includes practitioners, those working at country level, international organizations, trying to really provide a forum to sit together and to think about what are the strategies that we can use in this field. What can we do to address corruption in the health sector? Of course, in the title of the group, we have the SDGs. So what we recognize that we can't just work in the health sector. Whatever action we take in the health sector, it has implications for the sectors, development and so forth. So I would like to invite you to have a look after this seminar, to have a look at our website, to have a look at whether you want to join. You don't need to be a member of Health Systems Global. You could just join the group for free. So our colleague Johanna Manga, who is representing HSG, will post the link, the joining link in the chat. So please join and consider joining. It wouldn't be a lot of work. It would be not so many emails. What we do seminars, we do various joint sessions at conferences. But the idea is that we really try to do something about addressing corruption and creating this kind of momentum to do that. So one of the really interesting seminars is today, and I would like to introduce our participants. We have here two speakers who are going to talk about an intervention which uses addressing social norms in Tanzania in order to address bribery. And we always say that this is a difficult thing to do. We can't change culture, we can't change social norms, but maybe we can. And we have very limited evidence in this field. So I'm very excited to introduce our presenters. So the first presenter is Dr. Claudia Baez Camacho, who is the head of public governance at the Basel Institute of on Governance. And she's internationally known specialist researcher, practitioner who is working both on research and technical assistance to bring about solutions to corruption and testing different approaches. She is particularly specializing in the role of how we can work with social norms and what we can do to work within the grain and accepting the political environments, the complex environments in which anti-corruption solutions manifest. So our second speaker is Dr. Richard Sambaiga, who is a senior lecturer at the Department of Sociology and Anthropology at the University of Dar es Salaam. He holds a PhD in social anthropology from Basel, but his main work has been on anti-corruption, security, this social transformation. So again, these two speakers, I would like to give them the floor and ask them to talk to us, and then we'll have opportunity to ask questions. So I would like to ask you to possibly ask your questions in person. We'll unmute you, and you just unmute yourself. And when we go to the Q&A segment, it will be much more fun, and we are here quite informal group. So now it's a good opportunity for us to hear from you. But if you prefer, you could also put your questions in the Zoom chat. Thank you very much. So over to you, Claudia.
Thank you, Dina, and thank you to Health Systems Global for inviting us to do this presentation, to talk about our work in Tanzania. So I'm going to share my screen. I hope that you can see my presentation. Let me make it big. Okay. Do you see my presentation in full screen?
No, we see presenter's view.
Okay, this is not good. Well, then, just not to waste time, I'm going to stay like this. I think it's better. Okay, so we're going to discuss and present a project which we conducted together with colleagues also from the Behavioral Insights team and the University of Utrecht. This was a project funded by the Global Integrity Anti-Corruption Evidence Program, an FCDO-funded initiative. And basically, it is very much the spirit and the intention of GIAs to encourage researchers to come up with evidence-based approaches as to what works in addressing corruption. So more or less stop admiring the problem and describing what corruption looks like in health sector, for example, in our case, and move to the next step and actually testing interventions and trying to find out through rigorously measuring impact what can work to address corruption. So this is this project comes from a long history. Together with my colleague Richard, we've been working on looking at corruption in the health sector in Tanzania for a very long time. We have been mapping how social norms of reciprocity and gift giving are very much linked to the prevalence of bribery in health facilities. So after doing a lot of this research and admiring the problem, if you want, we decided to move to the next step and to develop an intervention to tackle this problem of bribery. And as Dina said, a lot of people think, well, we cannot change social norms. I hope that we'll be able to convince you after this chat, at least a little bit, that it is indeed possible to change these kind of behaviors. So the objectives of our project were really, we wanted to test an intervention to reduce bribery in health facilities in Dar es Salaam. We wanted to address whether it's possible to work and change social norms of corruption. And also, one of the things we learned from our research before is that, you know, corruption does not enact itself in a vacuum. And normally, when we're looking at social norms as associated to corruption, these are implemented and enforced by social networks. So recognizing the importance that social networks have in influencing our behaviors and our choices, we wanted to test also whether it's possible to work through social networks to change the attitudes and behaviors vis-a-vis bribery. And since we're talking here to a public health community, I'm sure you might already be familiar with this idea of using social networks as the delivery vehicle to for interventions and so on. So I'm going to speak a little bit on some of the preliminary work we did in the course of designing the intervention, because we want to make this very practitioner oriented. So we want to share our experience, what this was like preparing and really setting the stage for designing our intervention. So first of all, we had to confront unexpected results, because after years and years of researching bribery in health facilities in Dar es Salaam and actually identifying that this was a very widespread and actually endemic problem, when we were getting ready to design our intervention, we did some surveys and some additional research, and we found that corruption and bribery was not as widespread anymore as we had seen in our previous research. So we had to find out what's going on. Why are we getting these unexpected results? So we did a lot of additional research to understand what was happening. If there, space and interest, we can elaborate more in the Q&A, but long story short, what we found is that a more stringent anti-corruption approach from the top, from top down, from the presidency, starting with the presidency, but then also, percolating down to the health ministry and so on, had actually decreased the amount of extortionary bribery that was going on. So the health workers extorting bribes out of patients. But what we found out as well was that corruption, this didn't mean that bribery had completely disappeared. Rather, what we found is that it morphed. So rather than extortionary bribery, now what we were catching in our research was a more proactive bribery on the part of users. And this is where the social norm aspect comes in, based on the expectation that unless you give a bribe, you are unable to get good and timely treatment. And the expectation that everybody, in the health facility is doing the same, then this is the social norm aspect that is fueling, proactive bribery on the part of users. So we really had to zoom into this behavior, really try to characterize how is it happening, is it happening before or after treatment has been received? Also, what is the narrative that the people who are involved used to describe this behavior? How do they talk about it? We found that, when it comes to these interactions, both health providers and users speak about gift giving, although interestingly enough, on both sides of the table, our interviewees were calling it a gift, but at the same time saying, well, there is an implicit expectation that if you give a gift to a nurse or to a doctor, a relationship has been established, and it's a relationship of reciprocity, whereby going into the future, the gift giver is entitled to receive privileged treatment from the health workers. So people used proactively this gift giving to co-opt health workers into their social networks. And based on this assumption of reciprocity, the relationship projects into the future as an exchange of favors, which of course exacerbates and perpetuates the bribery patterns. So after characterizing this behavior, we tested different anti-bribery messages to try to find out what would be most, what would be most meaningful for our target audiences. And interestingly, we found that for health workers, the message that was most impactful was that appealed to their professional ethics and their professional integrity. And this was very useful for us also to decide which stakeholders we additionally needed to engage in our intervention. And with this information, we were able to invite and engage the Medical Association of Tanzania, who became the representative and the voice piece, if you want, of the intervention vis-a-vis the health workers, which we thought was a really good and powerful thing to do, because in the end, from whom the message is coming makes a big difference. So we tested different interventions approaches. We tested different data collection tools before going in the field. So this is all just to tell this audience of practitioners that yes, there is a lot of work behind designing such an intervention, but we really believe that this is the way to go to be, rigorous and evidence-based. So now I'm going to hand on to my colleague Richard, who will describe what actually we did with the intervention. So over to you, Richard.
Yeah, thank you, Claudia. I hope I'm heard out there. So basically, the intervention components are constituted of three major dimensions. So, but before I go to the dimensions, let me say a little bit about the premises behind these dimensions. So we thought that in order to change social norms around gift giving, and of course, to ultimately change the behavior, we need to know and address what are the underlying motivations for giving gift, either on the part of the patients, but also for receiving gifts on the part of the practitioner. And of course, that made us target both the patients and the health facility staff. And from the health facility staff, we had to recruit what we call champions. And these were staff from the participating departments or wards in the health facility. And in this case, Mwananyamala Hospital, one of the hospitals that were considered then as more vulnerable, or rather to bribery, where bribery was so to speak, much more prevalent at one point in time, and we thought that gift giving would be more prevalent also in this particular facility. So we recruited staff from the departments, which of course attracts more patients to the facility, and we trained them during the what we call the champion workshops. So we invited them for a workshop where we had to take them through of course, the intervention, but also get them buy-in the idea that gift giving was professionally unacceptable, and it was actually a driver for bribery, so to speak. And initially, it was not easy to convince them. I remember in this discussion, we had a heated debates on why is it that accepting a gift from a patient is a problem, because we are not inviting them to give us. It's them who are, having appreciated our service, they give it to us. And we had a long talk here, and to the point that some of the practitioners actually accepted the fact that it is actually a burden on them. When they accept a gift, it actually becomes an opportunity for the patients to now demand for a lot of favors, not just when they are coming to the facility, but also even if friends would want to come to the facility, they would give them a call. I have a friend who is coming there because you have already established this sense of reciprocity. So we tasked the champions to disseminate the anti-giving messages, anti-gift giving messages to the rest of their colleagues within the departments and within the facility. But after the champion workshops, we also designed the messages now to be actually a mechanism to change the attitude of gift giving within the facility setting. So we designed signs with anti-gift giving messages already defined, with feedback from Matt, but also feedback from the champions, and which would be put on the desks of the health providers. But also we had direct messages to the providers through SMS, also letters. We had to put up letters from Matt going to the health providers describing gift giving kind of agenda. So these and the SMS were going through a WhatsApp group which involved all the champions from the health facility. But also besides the provider facing messages, as I'll show it later, we had the patient facing messages. And for the patient, we had a poster or posters around the health facility which were actually prescribing why it is not necessary for them to give a gift, and that they were entitled to the service rather than normalizing giving gift in order to justify, or rather to entice the provider to give them quality service. And of course, to the patient, they would also have messages facing them on the desk when they are approaching the provider. And I think Claudia will show the next slide, which has the intervention materials. So I was talking about the sign which is talking about message to the patient, and it is just saying that help us to comply to our professionalism. Don't give gift, even if it is just a sign of appreciating our service. So a patient would be confronted with this message at the desk of the provider. And but at the same time, we wanted, this was based on the discussion of the champions and of course our explorative research. Providers had troubles and difficulties to reject a gift from a patient, and we had a message showing them that to accept a gift from a patient is one of the drivers of corruption. And so we were encouraging them to actually uphold their profession, integrity by not accepting gifts, and to give them some steps to take in order to reject a gift without actually embarrassing the patient who is giving a gift. But also you have on the other side a poster which is showing signs that a provider is rejecting a gift from a patient, and of course a message which is saying the Ministry of Health considers gift giving as a driver to corruption. So don't give a gift, even if you feel like it's just an appreciation. In case you want to appreciate, follow the right procedures for appreciating service from our providers. So these were the major intervention materials that were displayed within the health facility for actually our intervention to be complete. And the next slide, you'll see the champion workshop, basically involving all the members, recruited from the respective departments and wards within the facility that we had to do our intervention. I think from there, I want Claudia to come in and tell us how did we tackle the social norms through these messages. Over to you, Claudia.
Thanks, Richard. Yeah, so it's worth spending a moment on discussing how we address the social norms issue. So just to be a little bit technical, bear with me for a second. There are two different types, generally speaking, of social norms. One we call descriptive social norms, and these refer to what one believes people around us are mostly doing. So what is the most prevalent behavior amongst people in a similar situation as we? So in this case, the social norm was users were coming to the health facility assuming that other users were given bribes. So that therefore this was a normalized and common behavior. So that's one type of social norm. So therefore, I might end up giving a bribe because I think everybody else is doing it, not necessarily because I'm convinced that this is the right thing to do. So this is the first type of social norm. The second type of social norm is an inductive social norm. And this is about what I think people around me consider to be acceptable behavior, and where breaking this rule will incur me some kind of cost. So this can be, I will be gossiped about, I will be criticized. So it is about what people think that is the acceptable behavior. So basically, we wanted to tackle both types of norms. And what we did, on the one hand, to tackle the descriptive norm, that's what we use the intervention materials for. We believed that by placing our intervention materials very prominently in the wards and the departments where we piloted the intervention, that this would send a message, like if you, like Richard said, if you're sitting, facing the provider, and on the desk there is this sign saying, gift giving is not allowed, that this would communicate a message that in this health facility, this is no longer the norm. So this was our approach to tackle the descriptive norm. And then the approach to tackle the inductive norm was precisely with a network of champions. So the idea was we need to work with facility staff who can then take the message as their own and disseminate it amongst their social networks in the hospital. And the idea is that, it matters who the message is coming from, and that if you're getting a message, that is challenging and asking you to change your behaviors, and this is coming from somebody with whom you have, a routine relationship, somebody from your social network, somebody you trust, this is going to be more impactful than a simply, if you want, anonymous public awareness campaign or something of the like. Another word on the social norms, our main measurement instrument to look at impact was an exit survey. So we were measuring on the side of users, and then we also had quite a lot of in-depth interviews with the health facility staff and with users as well to complement the survey. So just a word on how we measured social norms and social norm change in our instruments. The main thing we did was to use these called things vignettes. And vignettes are, it's very simple. It's a quick depiction or a situation that will help the respondent understand what it is that we're talking about. But it's a strategy to try to minimize social desirability bias. And this is very important when we're dealing with topics to do with corruption, because it's very difficult for people to, accept openly that maybe they are engaging in some kind of bribery or, otherwise corrupt behaviors. So using vignettes, it's an opportunity to test, how people feel about a particular behavior. But as you can see in this example, here we're talking about somebody called Mary. So it's an external third person, and we're describing a situation where this person has received treatment, has recovered well, and gives a gift to the provider for the treatment. So we have framed what the behavior is, and then in the survey, we had follow-up questions. So what do you think about Mary's behavior? Do you think Mary is now entitled to better access than somebody who didn't give a gift? So we follow up with follow-up questions. We also ask once, a few questions about Mary have been asked. We ask the respondent, do you identify with Mary? Do you engage in such behaviors? So it's a research strategy that helps us measure and try to get sincere responses from respondents on topics that might be sensitive. I also wanted to talk a little bit about the network component of our intervention, because what we wanted to be rigorous and also measure whether this idea that communicating messages through social networks is impactful and powerful. And so to do so, we made use of a special software, which is called Network Canvas, and it's a free open source software, which our enumerators had on their tablets when they went about doing interviews with the health providers. So it's a very nice software because it allows you to upload the names of the facility staff And then you can ask people about their social connections and social interactions. So how often do you talk to these people during a regular week? And then you can move the bubbles, no, which represent the people with whom the respondent is connected. And one can categorize the strength of the social link. And then, of course, we had questions about how often the health workers were speaking to other health workers about the intervention. So we were able to trace, by using this software, how the message disseminated through the social network. So, and sorry, here it says preliminary results, but this is wrong. These are the final results. Apologies for that. So we did achieve large and statistically significant reductions in our survey-based figures. And I would draw your attention to this finding here, where those responders who would consider giving a gift in the future, the percentage went down from 43 to 25%. Which we think is really remarkable. Interestingly enough, people are very reluctant. I mean, it's very difficult to say. Our baseline was very low in terms of respondents who agreed or acknowledged that they had given a gift. It was only 2.8% in our baseline. That went down to 0.7% in the post-intervention measurement. So, you know, it still went down, of course, which is good. We still, you know, were left wondering whether the baseline was really reflective of a, you know, very low propensity to give gifts to begin with, or whether this number was more a result of the social desirability bias. But I don't know that we'll ever know that. Another nice result, if you look here, the percentage of those who believe that a doctor is socially obliged to accept the gift went down from 60 to 47%. So very nice results. We're very encouraged. And so now the question is, we think that we have tested an approach that has demonstrated its potential for impact. So that is, of course, a good thing. But in our opinion, this is only the beginning. The next questions that we would like to explore and that we think are necessary to explore is, first of all, how do we lend sustainability to this intervention? So we've worked in this hospital in Mwananyamala, as Richard said. We trained the champions, and I have to say, I personally was very pleasantly surprised with how enthusiastic, you know, even if they were reluctant at the beginning, they were really, really enthusiastic in their job as champions. And they really liked that they were giving the agency, you know, to engage their colleagues, to speak to colleagues. They even went beyond and engaged users, and they were quite appreciative of that. So we have this base of motivated champions. How do we keep this going? What would be follow-up activities to further, deepen and even institutionalize the results that we have achieved in this particular health facility? So that's one thing that remains to be done. The second one is, well, we think that we have an approach that seems to work. So how do we scale it up? If we look at other similar hospitals in Tanzania, what would we need to do to scale up the intervention? How do we mainstream the approach? And do we need to tweak? What do we need to take into account in order to maximize impact as we're scaling up? So this is the second question. And then the third question is related, you know, at the beginning, I told you about all the research and the effort that went into designing the intervention and getting it right. So this means, I'm going to be completely honest with you, it was time consuming and expensive. So to me, this means, for a practitioner's perspective, if we believe that we have produced evidence that this approach works, how can we take the advantage of this? And can we use a similar approach to tackle other problems of corruption, and maybe even in other sectors. So this, like I said, I think this is only the beginning, but I'm very convinced, and I think I speak for Richard as well, we are very convinced that it's absolutely fundamental to start with evidence-based impact, to show evidence-based impact, and from there we can explore issues of scaling up, of generalizability, etc., which can then justify the relatively high initial investment that goes into designing this type of interventions. So I'm going to stop here, not before I acknowledge our team. Like I said, Richard was my co-investigator, but we also had a team of wonderful researchers from the University of Dar es Salaam. And we had also a wonderful team, including the Behavioral Insights team from the UK and a colleague from the University of Utrecht, who is the expert in social networks and social network mapping. So I'm going to stop here, and I look forward to questions and discussion.
Much. This was incredible, extremely interesting. And I don't see yet comments, but I would like to invite everybody to think about what they want to comment on or ask questions. I would like to ask you something. So I found these results absolutely incredible and very promising. I take your point that we need to first work on this idea of creating islands of effectiveness. Once you have demonstrated something can work in one facility, it creates hope, it triggers organizational change. There is a lot of organizational literature around how this could be used to inform and to scale up. But even before you have the evidence that it's working more broadly, that could be almost a trigger for change. But I would like to ask you, so I'm coming from a country, and my PhD was in Bulgaria, where in Eastern Europe, the culture of giving gifts is so ingrained. You don't go to a teacher, you don't go to a health worker, you don't go to a whoever in the public sector without giving something. There's been historical work around that people in the past, there was no government funding. People were in a village, they will co-fund somebody who is the local priest or the local doctor or the local whatever. So this is very deeply ingrained. So my question to you is, was there something like that in Tanzania, which is beyond the health system, something that you were fighting against in a way that's bigger? That's my first question. And I would like to also ask you to then elaborate a little bit more. You said a little bit, but maybe a bit more on the process of deciding exactly the type of intervention. You did say a bit, but I think that's something we are struggling quite a lot, because even when we do co-production, and you did a lot of co-production, there are different views of, and given the lack of literature, the lack of evidence, how do you actually, a little bit more on how were you sure that you're doing the right things? Because we know that every small tweaks, for example, you were talking about putting posters. We are having even information that if you put the poster in the wrong place, it may have the opposite effect because people feel they're observed. So my question is about exactly what was the process, a bit more information, and generally this issue about the culture. Thank you.
Okay, great questions, Dina. Thank you. So I'll tackle the first one, but also then, of course, defer to Richard because he probably knows much more about this than I do. But based on the research that we've done in Tanzania now for more than, I don't know how many years, but certainly more than 10 years, yeah, I mean, this kind of reciprocity, gift-giving, linked to bribery expectations is not restricted to the health sector. It's part of a broader pattern where, you know, informal relations and informal connections are sometimes even more important than the formal prescriptions and regulations. So who you know matters, and people instrumentally use their social connections or even build social connections to address problems at hand. And I think that you know, for me, what is underneath, these are, in my opinion, for the most part, very pragmatic transactions. So you offer a gift a gift, a euphemism for a bribe, to get the service you need, because there's a huge waiting line. So there are these underlying bottlenecks where the demand might be overwhelming the supply, and we know that health workers, not only in Tanzania, but in many, many countries, are overworked, and there are severe human resource scarcity issues there. So a lot of it has to do with these kind of systemic issues. Part of the research that we've done would tend to confirm that, in that, for example, we did a study on social norms and corruption that included not just Tanzania, but we also looked at Uganda and Rwanda. And in Rwanda, as I'm sure many of you know, they have a very strict anti-corruption approach, but also they have invested massive amounts in improving their health services. And with I'm going to probably say something that is not at all correct, but bear with me, with similar social norms and cultural understandings about social relationships and all of that. In Rwanda, people were telling us, I come to the health facility, I get treated immediately. There's no need to give anything. There's no need to resort to the network. I just don't need it. So I think that these issues are very much underneath. But I'll hand over to Richard, who can elaborate more about what is the Tanzanian context.
Hello, Claudia. I think you nailed it. So basically, to cement your point, it is true that the whole practice is cultural. And not limited to the health sector. So there is this culture of reciprocity. Is if somebody does a good thing to you, you ought to reciprocate. And so much so that it becomes a norm when you are also given services that you were even entitled to. You feel like I need to do something so that I become a good person. So a good person is the one who follows the norms and the values. So I would just, say that it is somehow a cultural practice, and that's why when we were discussing with the champions from the health facilities, in the first place, they were very reluctant. Say, why is it a problem? I'm not inciting it. They are just voluntarily. And they were actually telling us, somebody, after being attended very well, they may not give you instantly. They may actually, some people may travel back to their homes if they are not from the city, and send back from their regions, up country, sacks of either maize or rice, things of the sort. It may not just be cash, it can also be in kind. So it is it's actually heavily ingrained within the social cultural practice and values. So, challenging it when it goes now in the public, in the formal setup, it requires actually changing the attitude in the first place, and we need to do a lot of mobilization to start with. So I'll also, leave it at that, and we can take it up in the next questions. Thank you.
Thank you. Thank you. This was brilliant. Thank you very much. We have a few questions coming up, and I would like to give the floor to Eva. Eva would like to ask a question.
Yes, thank you so much, firstly, for the wonderful presentation. Super interesting. My own research is on social norms and anti-corruption, so it's great to see more experimental evidence on that. And also, so my initial question was going to be on sort of gratitude payments and gifts, because they're very commonly in the literature sort of divided from what we conceptualize as bribes, even though while the intention is different, the outcome is quite often the same in terms of these network externalities. So I thank you for your comment on this. That was really interesting. So I wanted to kind of go back to the scalability issue that you were talking about. And I was wondering, at what stage of their careers were the doctors that participated in the experiment? Because I can imagine that it's much easier to introduce an intervention like this at a very early stage where you have, let's say, a course with multiple doctors and you can start testing this sort of information prompts. Yeah, thank you. Thank you again.
Thanks, Eva. And I'm so excited to hear you're also interested in social norms and anti-corruption. Fantastic. So actually, this question is really good because it also links to what Dina was asking before about the co-design process. Because, you know, we really thought very hard in the core research team, what kind of profile are we looking for the champions? So we wanted people that would have some degree of centrality in their social networks. This was one of the most important things because we wanted, you know, to achieve the most impact through this network dissemination effect that we were hoping to see. We made a lot of, you know, we had a grid with all the different characteristics, so many males, so many females, so many nurses, so many, you know, we did the very nerdy academic thing. And then when it came to the selection, I mean, of course, we were working very closely, not just with the medical association, but also with the hospital management. And both the medical association and the hospital management said, no, we're not going to use your criteria. We are simply going to take the heads of units, you know, of the treatment units that we had picked in the hospital, and then they will pick subsequently a second person in their team. And we thought like, oh no, this is terrible. Now we have a hierarchical element here. It's going to distort things. But, you know, in the end, I think it worked out well because and here I think that having the medical association and having the management on board make a huge difference because they also address the champions, you know. So it was not an intervention coming from this strange group of, you know, nerdy researchers, but the medical association and the hospital management were the face of the intervention vis-a-vis the champions. And I do think that you know, what matters here, or at least this is how I reflect on it, and you're a social norms scholar, so this will sound familiar. We all have very different identities, right? We are, you know, daughters, wives, a professional, a nurse, whatever. It really matters which identity you prime in order to change attitudes and behaviors. And I think that here, having this professional angle where with a professional association and the hospital management really helped encourage the champions to be motivated and go out and do what we asked them to do. And in terms of the co-design element, this is just one example of how we, you know, in our intervention, because we really went on the field and we were really dealing with the actual stakeholders. We were not doing, you know, experiments with university students or anything like that. There were many instances where we had to compromise, where reality just imposed different criteria and conditions to what we as researchers would have chosen in the first place.
Thank you, Claudia. I hope this answered the question. However, we have another question which is actually related to what you're just talking about. It's why would the champions do what you're asking them to do? Why? What motivates them to get involved? Because it's extra work, extra sort of where there's some incentives that may have influenced, because that's important if we're thinking of replication.
I don't know, Richard, you want to come in? you were very closely involved working with the champions.
Yes, I can come in and you can add Claudia. So basically, through the champion workshop, we had the head of the facility who actually seriously bought in the idea. So he was the #1 champion, and he wanted the reputation of his facility to actually change, because previously there was a negative reputation attached to the facility, and he came in with this zeal wanting to change things. And when we went with the project, he thought this would be an opportunity to actually realize that mission. And so, but secondly, we had the MAT, the Medical Association of Tanganyika, who were actually present at the workshop of the champions, and they gave because anti-corruption and professionalism and integrity to the medical professionals is part of their mission. They want to realize that. So they also had the opportunity to sort of sensitize the champions. And of course, we were at the end of the day issuing a letter of appreciation from the MAT, the Medical Association of Tanganyika, actually endorsing or even appreciating the role of the champions in the actually fight against unprofessionalism, and in this case, anti-corruption in the health facility. So at least there was that incentive, wanting to do something that would be recognized by the head of the facility, but also by the medical association. This is a professional body which matters. It actually endorses the license of the medical practitioners in Tanzania. Over to you, Claudia, for an addition point. Thank you.
No, thank you, Richard. I think that you covered everything I would have said. And I think there's another question, right, Tina?
Yes.
Maybe we should.
Yes, there is a question again about you mentioned the social desirability. You mentioned that in a way it's difficult to know what people say, what kind of, and we find that very often people in kind of, although you were in the field, you're not doing a lab research, but still people feel they're in a experience, they know this is a study. So it's a artificial, a little bit environment. So yes, is there any additional research that has followed up to really see that this type of behavior has reduced, or maybe not yet?
Yeah. So it's a great question, Annette. Thank you so much. The quick answer is no, we haven't really been able to do follow-up research. What we have are we did very, very comprehensive data collection for the impact measurement. So we not only did the survey again, but we also did extensive interviews. So from the interviews, we got some very nice insights as to how, people took the intervention, understood the intervention, and reacted to it. So for example, some users said, I'm actually relieved to see those signs because I'm poor. I don't have money to get, to pay a gift, to get a gift. And this is actually relieving the pressure. And that's just one small example, but there were others that gave indication that at least some kind of behavior change would ensue. Now, we don't have the evidence to back it up, and we are desperately fundraising to do a follow-up study because these data collection that we did for the impact measurement really suggested that people were very motivated. What Richard spoke about, that some of the responses we got even from health providers who were not champions. People were asking, how do I become a champion? And we didn't give them any money or any financial reward. It was really a thing of status that probably had a lot to do, like Richard said, with a professional association being involved and the hospital management. So we really hope, if you know of any good grants opportunities available, let us know, because we are really, really keen to do the follow-up study to go more into detail into the question.
This is brilliant. So thank you very much. We have one or two questions, but I would like to very quickly ask one question that I've been burning to ask. What is the size of the typical size of a gift? Because we find that that's sometimes distinguishing factors. For example, if people give a box of chocolate and something, sometimes actually they could give a tiny gift, but for them it's a lot because they're from lower socioeconomic group. So my question is there something, a gift that's actually just a gift because it's tiny? I mean, can we use this criteria to distinguish, or this makes it even more complicated? And then we have one more question before we finish.
Yeah, I mean, this is obviously a very important aspect, and we had many discussions among the team. I think that the experience, what we captured from the Tanzanian case, is that gifts really can be anything and everything, and then they can be very, very small, you know, like Richard was saying, some sack of rice or some food, a cake, something like that, to actually money, no? And the amounts vary a lot. So I don't know that we could go in the direction of setting a threshold to decide from up to here, it's a gift, but if you go over, then it's.
By the way, some high-income countries have done that. High-income countries, for example, apparently in France, we were talking to people, professional association, and even in the UK, there is a little bit of what you can accept and what not. It's part of this integrity kind of guidelines. But really interesting. Thank you. There is something to still think about. There is a great idea already from Annette for further funding opportunities. So that's beautiful. Thank you very much, Annette. So I would like to just ask the final question before from Barakat. How do you measure, ensure the adequacy of champions part of the intervention? Was there any standardization of intervention to make sure that in a way it's the same thing that they're doing that's quite standardized and we can attribute the results to that?
Yeah, I'm going to answer, but I'm not sure what exactly, Berkat, you mean by adequacy. Basically, for us, what was important was that the champions, you know, really internalized and owned this idea that receiving gifts from patients is bad for everybody, you know, in the long run. And then with this idea, we gave them the freedom to run with it. And we did ask them, please talk to your colleagues about it, but we never said how, when. We didn't set any boundaries as to who should speak to whom. Also because this is, you know, to our, you know, to what we know, this is a very novel approach. So we didn't want to limit outcomes based on on some preconception that was not empirically validated. And I think this worked. Most of the champions were happy and enthusiastic, and some of them even pointed out to this precise fact that they were given the freedom to use their, you know, their creativity and their ingenuity to perform the role as champions. And I personally think, without having, you know, a strong evidence to say so, but it's my gut feeling that by giving the intervention participants agency, I think that this is a very important element in putting in the seeds for sustainability. Because if people are owning the role, are making it theirs, then I think there's a higher likelihood that they will want to carry on than if they are simply following instructions within a more rigid framework. So I don't know, Berket, if I answered your question. I hope I did.
I think that's a really important point that you're making, that you could over standardize and doing that may reduce the opportunity to adjust to every facility. The fact that every area is different, every facility is different. Anyway, I would like to now thank you for this. It was incredibly useful to hear. It's really one of the few experiments of this sort, and I would love for us to read the papers, to read the further sort of information once you kind of describe the whole thing. It will be extremely important, and we'll publicize through the group. And I would like to invite everybody again. We've pasted the link in the chat to consider joining the group. The group is very much, we're having seminars like that, but we're also planning some opportunity for other joint action, very often writing papers, so connecting people to each other. We also sometimes have funding opportunities because we connect to funders. So we have had a few members who got ideas from the group and they actually got the funding, and presented their results. So please join the group, and we would like to hear more, maybe another seminar from you, Claudia, what happened later. If you do have the additional funding or follow-up, we would love to know what happened later. And thank you very much, everybody, for staying and for participating. And I would love to connect more with you on other seminars. Have a great day. Thank you.